Yeah, let's move on to our next session. So heart failure workshop we have. And I'd like to call our chairperson, Dr. P.C. Mandal. He's a senior interventional cardiologist. Dr. M.L. Bhansali. He's a senior physician. And Dr. K.S. Poddar. So Dr. Poddar unfortunately is not here. Fine. Now this session has been divided into 3 parts. Would like to call Dr. Arindam Pandey. He is an interventional cardiologist, medical super specialty hospital. Dr. Sumit Banerjee, sir. He is a senior interventional cardiologist. Can I have more chairs on the dais? It's okay. I think after the lecture, and Dr. Sunil Iyar, he is a senior interventional cardiologist. R.N. Tagore. Over to Dr. Arindam Pandey, sir. Yeah, sorry.
Good evening, friends and my seniors. In next hour, we are discussing a very important topic of heart failure, which we are getting in our day-to-day practice, and more than 1% of Indian population is suffering with heart failure. And we know that we can prevent it by appropriately treating diabetes, hypertension, dyslipidemia, coronary artery disease, obesity, but still there is epidemic is going on for heart failure. So I will invite our first speaker, Dr. Arindam Pandey, who is consultant cardiologist at Medica Super Specialty Hospital, for his topic of heart failure with reduced ejection fraction, how to start in hospitalized patient, and what is GDMT therapy, how to go with it in various situations. Welcome, Dr. Arindam Pandey.
Thank you, respected Chairperson, Dr. Mandal, Dr. Bhansali, and everybody who are present over here. So, as Dr. Bhansali was mentioning, heart failure, it's very prevalent. 1% of Indian adult population might be suffering from heart failure, but I would like to mention the fact that this is not only a prevalent disease, this is a very high mortality situation, not a good thing to have. So 5-year mortality of heart failure, reduced ejection fraction, if you see the global data, it is 50%. So 5 out of 10% across globe is going to die if they get this diagnosis after 5 years. What about Indian data? Trivandrum Heart Failure Registry is one of the registry which has suggested probably our data is even bad. So 3-year mortality is 50%. So 10 patient, whoever is getting a diagnosis of heart failure, reduced ejection fraction, out of these 10 patient, 5 will die within a span of 3 years. So this high mortality is more than many of the cancer, deadly cancer. So very serious condition, and at the same time is very prevalent as well. So I'll be talking on whether we can initiate the therapy, whatever therapy has shown to improve the mortality of this kind of patient early. So before I go ahead, as I assume there are many non-cardiology, I mean physician, general practitioner is also there in the audience. So I'd like to briefly go upon the classification and gross nomenclature of the heart failure. Though we all know about this, so heart failure is grossly divided as per the ejection fraction. So we call them heart failure reduced ejection fraction if the ejection fraction is less than equal to 40%. 41 to 49, there had been some confusion what this group of patient will be called. Now we have a clear-cut nomenclature. We call them heart failure with mildly reduced ejection fraction. Now if the ejection fraction is more than equal to 50%, then we call them heart failure with preserved ejection fraction. Obviously anybody is having ejection fraction of more than 50%. So they should be having features of heart failure, other biochemical as well as symptomatic features of heart failure. Now out of this 3 nomenclatures, something new is also there, which is known as heart failure with improved ejection fraction. Say for example, someone who presented to you initially with a ejection fraction less than 40%. Now you gave him some therapy, either some medication, pharmacotherapy, lifestyle changes, or some intervention, CRT and so on. Now with your therapy, the ejection fraction now has improved. So ejection fraction now, for example, is 45% or 55%. So how would you classify them? We'll not call them preserved or mildly reduced ejection fraction. We'll call them something else. It is known as heart failure with improved ejection fraction. Does that hold some importance? Yes, because in terms of therapeutic intervention, I'll show you the data. If you stop the medicine or the therapy which resulted in improvement, then again the ejection fraction will come down. So we actually cannot categorize them as preserved ejection fraction heart failure. Fine. So with that, I would also like to remind the fact that this ejection fraction, the classification of heart failure is interchangeable. Someone who is now preserved ejection fraction heart failure may turn down to be either mildly reduced or reduced ejection fraction heart failure. And there are clear-cut factors which are shown which may actually lead to this improvement or worsening of ejection fraction. So factors which are related to good recovery, say for example, young age, female gender, lower heart failure severity at presentation, or the duration of heart failure is low, then there are probabilities that this patient might actually improve in later life. Otherwise, there are other factors which are responsible for gradual worsening of heart failure. Now, at the same time, the ejection fraction classification, there is something known as stages of heart failure. So stages of heart failure, stage A is the heart failure stage where the risk factor for development, future development of heart failure is there. We had a fantastic session just before that, this diabetic session. So anybody, just presence of diabetes will entitle the individual to be having a stage A heart failure, because diabetes is an established risk factor for heart failure. Now at this, with this risk factor, if the patient develops some structural abnormality, say for example, ejection fraction in echocardiography has gone down, but still the patient is not symptomatic, we'll categorize him as stage B heart failure. Now this stage B heart failure, once they become symptomatic, they are classified as stage C heart failure, and actually in this stage, we physician get to encounter the patient. Majority of the patient, they do not come before this. And then if the heart failure symptom becomes refractory, we call them stage D heart failure. But very interestingly, stage C heart failure can have different trajectory. So it can be classified as new onset or de novo heart failure. If the heart failure is first time detected, then we can actually have a trajectory known as resolution of symptom. There are a group of patients whose ejection fraction goes up, improve of its own, say for example a viral myocarditis. Or some group of patients may have persistent symptom, persistent heart failure. And some group of patients, they will have recurrent failure, recurrent worsening of heart failure. So these four kind of trajectory we can see in the stage C heart failure. At this point, I would like to also mention there is another classification of heart failure in terms of symptom. We call them NYHA classification of heart failure. NYHA 1, 2, 3, 4. That is completely on the basis of symptom of the patient. And they are actually interchangeable. Fine, stage of heart failure actually is not interchangeable, but symptomatic class, someone who is having a class 3 symptom, if you give treatment at some point of time in future, he might be either NYHA class 2 or NYHA class 1. So that clear-cut idea we should all have. Now, why it is important to initiate treatment in hospital? We need to know the background, we need to know the pathophysiology behind it. So anybody who is hospitalized for heart failure, we used to call them acute decompensated heart failure. They are a very bad subgroup of patients, very high mortality. I'll show you the trajectory of acute decompensated heart failure or anybody who is hospitalized for heart failure. Now, we have seen anybody who is actually hospitalized for heart failure, they have a very high risk of future readmission or mortality. And I can clearly show you data. The number of hospitalization is clearly related to the mortality of the patient. So it's not a benign condition. Some heart failure patient going to hospital for therapy, this actually is a very important prognostic marker. So this is, you can see the heart failure trajectory. So why they have acute exacerbation, why they are getting hospitalized. So it may be an acute coronary syndrome which is precipitating heart failure. It may be an infection, commonest lower respiratory infection, or a UTI. It may be due to some anemic event. The blood, hemoglobin has gone down significantly. All of them actually can lead to heart failure. So it's always not necessary the heart has to be involved. And now we consider chronic heart failure similar to chronic ischemic heart disease, or a patient who is having chronic obstructive pulmonary disease or chronic kidney disease. So all these situations, we know there is some acute exacerbation, AKI in CKD patient. acute exacerbation in COPD patient. Similarly, we have changed our terminology of ischemic heart disease. We used to call them stable ischemic heart disease. Now we call them chronic coronary syndrome because they can also experience frequent exacerbation in the form of acute coronary syndrome. Similarly, chronic heart failure is a situation where there can be punctuation and exacerbation in the form of acute decompensated heart failure. Now we have a new terminology for this kind of situation known as worsening heart failure. So what does it mean, worsening heart failure? Any patient who is having a chronic heart failure, they either go to a hospital for some therapy or go to an emergency where the patient needs an IV diuretic. Now we also include the patient where oral diuretic dose has to be elevated. That also include the whole definition of worsening heart failure. And if you see the current many randomized control trial, they are actually taking inclusion criteria as this worsening heart failure. I'll show you some of the evidence. Now, this readmission and mortality are very common in any of the heart failure hospitalized patient. You can see this is the 5-year data. You can see the very high readmission, all-cause mortality, non-cardiac mortality as well. So, what about the trajectory? Anybody who is getting hospitalized, you can see in-hospital mortality of any heart failure patient is actually 4 to 6%. So that is quite high. 100 patients admitting for heart failure, out of this 100 patients, 5 is going to die within this span of hospitalization. What about the 30-day mortality? 2 to 3%, which is also very high. So 15 to 30% 1-year mortality, then subsequent mortality I already discussed. And you will be surprised to know 1 out of 5 patients will be readmitted within the first month of discharge. So that is why it is extremely important to optimize the therapy of heart failure, which has shown to improve the mortality of the patient. And this is actually a golden opportunity for all the physicians to interact, to initiate the therapy which can actually change the trajectory of this patient. Fine? So this is the reason. Because, say for example, I'd like to know your experience. My patient, whenever they are hospitalized, I discharge them, I do not see them before 2 weeks. So many of the physicians, they see them after 1 month. So you will miss the early opportunity to initiate medicine. So we also know that initial 2 weeks and initial 1 month is the very vital period where actually the patient should be under cover of very important lifestyle mortality changing medication. So that is why all the researchers, they have tried to evaluate the therapy, whether we can initiate them in hospital. So do you have evidence? I'll show you the evidence. This is the summary of the studies which actually evaluated the patient who recently had a heart failure event. So all these trials, these are all landmark trials, randomized control trial. So you can see from the right, Impulse trial, which evaluated, empagliflozin to initiate it in hospital. Similarly, Pioneer heart failure trial evaluated ARNI for in-hospital initiation. There is another trial known as transition trial. I did not mention it here. That also a trial where in-hospital initiation of ARNI was done. And it was shown that it is feasible and you actually can reach the optimal level of ARNI doses if you initiate the molecule in hospital. There is another trial known as Victoria trial, which initiated in-hospital initiation of therapy. We have a dedicated lecture by Dr. Leela on vericiguat, the molecule which was evaluated in Victoria trial. So I'll skip few of the slide related to vericiguat. Galactic heart failure I'm not going to discuss because the molecule is not available in India. Soloist worsening heart failure trial is another trial where a combined SGLT1 and SGLT2 was initiated in hospital. You can see the in-hospital initiation in soloist heart failure trial was around 50%. So 50% the molecule was initiated in hospital. So we do have good amount of data to support our theory that all the molecule of heart failure which can actually change the mortality of the patient should be ideally started while the patient is still admitted. Fine. So what does the guideline says? So guideline says, this is the 2022 AHA-ACC guideline. You can clearly see the patient with heart failure with reduced ejection fraction, GDMT should be initiated during hospitalization after clinical stability is achieved. So this is very important. All patient who is coming to you, who is requiring IV diuretics for stabilization, is not a fit candidate to start all these molecules. So there is some stabilization criteria. So what are those stabilization criteria? They also emerge from the trials, say for example, Impulse trial, Pioneer trials. All these trials, actually we get the information how we consider someone to be very, very stable to initiate this kind of medicine. Say for example, SGLT2 inhibitor, beta blocker, or ARNI. So I'll give you a brief example what we consider to be a relative stability of the patient. The patient should be off inotrope for at least 1 day. The patient should be off IV diuretic for at least 12 hours. His blood pressure should be reasonably stable for 12 hours. He is not on any oxygen therapy. And there is no escalation of diuretic, be it IV or oral, in preceding 24 hours. If your patient fulfills these simple criteria, you actually can initiate all the therapy gradually or together. There are two schools of opinion. Some people say you should try to initiate all the heart failure medication together, but other schools say no, go step by step. You can initiate initially the beta blocker, SGLT2 inhibitor, followed by ARNI, and at step 3, the mineralocorticoid receptor antagonist. Both are correct. Both have quite good evidence in favor of them. So I'll show you the goals of pharmacotherapy for patients of heart failure, because now we are very clear that all the therapy has to be initiated in hospital. So what are the goals? First goal is mortality. I mentioned it's a very high mortality situation. Then comes the prevention of recurrent hospitalization, because I mentioned hospitalization number is also related to the future mortality of the patient. Then comes the improvement of the clinical status, functional capacity, and quality of life. So this particular trial I'd like to mention, TRADE heart failure randomized trial. This trial clearly shown us that if we stop the medicine, which helped in improvement of ejection fraction or the symptom of the patient, say for example, the ejection fraction is now 60% from the baseline 40%, then the patient, good number of this patient will again worsen. So we are not supposed to hold any therapy which resulted in improvement of the symptom or ejection fraction of the patient. So what are the heart failure guideline recommendation? I'll briefly touch upon last few slides regarding the current evidence in this regard. This is the 2021 heart failure guideline. We all know about it. So these are the therapy. I can show you the class 1 indication in heart failure. So we all know about ACE inhibitor, ARB, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitor, particularly DAPA and empagliflozin. But many a time we forget that diuretic is also having a class 1 indication if the patient is having features of volume overload. So that is also a class 1 indication, though never any randomized control trial was done. Now if the ejection fraction improves, symptom improves, fine. But if the patient is still symptomatic, then we should look for other therapy which are also class 1. Say for example, ejection fraction is still less than 35% and the QRS in ECG is less than 130 millisecond, then the patient is a candidate for putting an ICD. If the patient comes from an ischemic heart disease background, past history of MI, angioplasty, bypass, then it is a class 1 indication to put a AICD to prevent sudden cardiac death. But if the patient is having non-ischemic background, then it becomes class 2A indication, because we know this is not an area which is out of doubt, because there is some doubt whether non-ischemic heart disease, non-ischemic heart failure will benefit out of ICD or not. But if the QRS is more than 130 and the initial management failed to improve the ejection fraction, there is a class 1 indication to go ahead with cardiac resynchronization therapy. So these are the common things, common guidelines. Preserve ejection fraction I'll skip because already we have a dedicated talk on preserve ejection fraction, so I'm skipping it. Now this is the final 1 or 2 slide, 2024 ACC expert consensus decision pathway for treatment of heart failure with reduced ejection fraction. There they have mentioned 9 commandments. So what are those 9 commandments to be followed in all heart failure with reduced ejection fraction patient? So initiate and switch, proper appropriate initiation of pharmacotherapy, titration. So for example, ARNI, you always try to increase the dose of ARNI, then only the maximum benefit the patient will get. Then if the patient is not responding, referral comes at stage 3, I mean the point 3, then care of the coordination. So other coordinator who are involved in the heart failure therapy, we should work as a team. Adherence of the treatment is very important. Our country is showing bad prognosis of heart failure because poor adherence of the patient. So specific patient cohort has to be identified, medication cost has to be assessed, whether it is going beyond the limit of the patient. So that has been mentioned. So increasing the complexity of the treatment, some patient will benefit from complex therapy, but majority of the patient, they will get benefit of the simple therapy which is easily available. So with that, so this is the staging I have already mentioned. Many a time people come and question whether all the SGLT2 inhibitors are same. I feel both the SGLT2 inhibitor which we use, DAPA and EMPA, are safe, very good in heart failure. They both have class 1 indication, both in hospital as well as follow-up patient. But if you see it in terms of mortality benefit, the mortality benefit in heart failure patient and also in kidney patient is there with dapagliflozin also. And only. And also there is a population, I mentioned, heart failure with improved ejection fraction. Only DELIVER trial evaluated this group of patient. So if you get this patient, then as per the evidence-based treatment, probably you should choose this dapagliflozin. And these are the dose adjustments, which I am not going to detail. So lack of response, when you are supposed to refer the patient, because many physicians, general practitioners are also listening to this. So these are the points I mentioned. I need help. This is the 2024 ACC referral pathway. If you find your patient is fulfilling this, so requirement of IV inotrope or the persistently elevated natriuretic peptide level or symptomatic class of patient, end organ dysfunction, so kidney dysfunction, liver dysfunction, persistently low EF less than equal to 35%, requirement of defibrillation or shock, hospitalization more than 1 time, edema despite escalation of the diuretic therapy, low blood pressure and high heart rate despite optimization, or prognostic medication, progressive intolerance or down titration of the GDMT. If you find your patient is having, probably they will need help and you should refer to a heart failure specialist. So with that, these are the essential skills for an heart failure team. You can see the importance of support staff, psychosocial aspect of the therapy, palliation therapy, that also has been mentioned. And some of the patients who are actually discharged post-hospitalization will benefit from cardiac rehabilitation. And I see role of remote cardiac rehabilitation, the monitoring tools which are actually now we can get tools which actually can be wearable. Also the smartphone, proper use of smartphone may actually help good number of patients. So with that, I'd like to stop here. Thank you very much.
Thank you, Arindam. Actually, this I need help and these 10 commandments, these two things in 2023 and also introduction of CKM syndrome, cardiovascular kidney metabolic syndrome, that was getting discussed for last 2-3 hours. All these 3 has been introduced in 2023. We'll discuss, I think, at the end of all when all the speakers will complete their lectures. But these 3 areas are very good area that to be discussed now. These 10 commandments, I need help, and what is CKM syndrome, that is also including the stages. Stage 0 is no risk factor. That means general population should be screened, not for biological factor only, but for also social determinants of health, SDOH. All these 3 is intermingled now to treat cardiovascular disease, because all roads lead to heart failure. It is an MI, it is an hypertension, all will lead ultimately to heart failure. That's why all are interrelated. So with that, we will go for the next speaker, that is Dr. Sumit Banerjee, and his topic of discussion is diagnosis and management of patients with heart failure with preserved ejection fraction.
Thank you, organization, AAPONCON, AstraZeneca, it is a sponsored program. Dr. Bhansali, my friend Prakash. This is the subject which I am going to talk on, the diagnosis and management in patient with heart failure with preserved ejection fraction. Now, the discussion you had since morning all have a measurable parameter. Kidney function is deteriorating by estimating GFR or albuminuria. Sugar control is optimum by measuring HbA1c sugar. But in heart failure, it's a tough task. Now, why it is a tough task? Because it's a question of suspicion. And Dr. Pandey, in his talk, repetitively mentioning New York Heart Association classification. And that classification is the key to the management and prognosis of heart failure patient. New York is a very old city which has blocks with a different fixed width and distance. So if somebody can cross one block or two block or three block, depending upon that, the Heart Association classification came up more than near about a century ago. Now, this holds for breathing difficulty, palpitation in absence of mitral regurgitation, aortic regurgitation, chest pain and fatigability. So it is not the question of breathing difficulty, it is the chest pain also in absence of coronary epicardial stenosis, atrial fibrillation or sinus tachycardia not being present, but the patient is complaining of palpitation and the fatigability. So these are the key four symptoms you need to elicit when you are suspecting a patient with heart failure. And this comes the first diagnostic criteria. So we have said the description of symptom, and many of us, this is 19th floor, it is difficult to come up with a stair, but some of us will hesitate to go from ground floor to second floor in these days, saying that ar pada jacche na, hapiye jai. So this may be a initiation of symptom. Along with this, ejection fraction of more than 50%. Now the problem is, my previous speaker has a tough task in handling a student who has not scored the pass mark, less than 50%, less than 40%. So he has to be given lot of coaching. So chatte coach ache, ACE inhibitor, beta blocker, SGLT2, MRA. So they can make this boy who failed in the pass marks to make him 50%. And there is another drug actually, which Dr. Leela is going to talk on and which help. But my problem is, my student is a good student. He has already scored 50%, but trouble is with him. So what is the trouble? Is he overburdened with his study? Maybe the student is overburdened with his study, or he may be inclined to something else apart from book, ugly thing, nasty things. So that's why it is difficult to understand this problem. And remember one thing, it is not the ejection fraction, it is the question of congestion, which comes as a symptom and sign. And even there may be no structural abnormality, only functional abnormality. Where it happens? Severe anemia in a pregnant woman, which gets corrected immediately after delivery or after giving correction of hemoglobin. A patient who has rapidly deteriorating end-stage renal disease before the heart has been jeopardized, he can have a high output heart failure and still the heart is normal. Now, keeping this thing in mind, you need to have a very clear, good history. Is the patient is aging? So, aging itself can produce symptom of heart failure. But don't think everything is aging. So don't miss the factor. Diabetes metabolic syndrome, what Dr. Prakash is already saying, is going to be a different specialty in the future. Physical inactivity. So many a times the most common cause of exertional breathing difficulty is physical deconditioning. and a combination of hypertension, CKD, sleep apnea, obesity keep you a more visible to a symptomatic patient that you are not missing a patient with heart failure with preserved ejection fraction. And these are the pretest probability. So if the more the age of the patient, the more the number of the risk factor, and more the subtle echocardiographic dimensions. So just don't look at the report, try to find out whether cardiac LV mass has been picked up by a good echocardiographer, a left atrial enlargement has been picked up, and a diastolic indices, which is E by E prime, only possible if the patient is in sinus rhythm, has been picked up or not. And then you can think that the patient is having heart failure with preserved ejection fraction, and this is the diagnostic algorithm. You need to remember this thing. First you have to suspect, and many a patient who are very much obese, you can have a near normal NT-proBNP. So heart failure with preserved ejection fraction give value less to the NT-proBNP but more concentrate on the patient. So I take you to a patient who is a 66-year-old lady, diabetic, hypertension, obesity, presented with class 3 dyspnea and bipedal edema. So these are all substrate for heart failure with preserved ejection fraction. And if you see the patient face, you can understand very clearly she has a short neck and she is obese. You cannot see from these faces, but definitely you can predict. And you can see the ECG, which has a definite right bundle branch block pattern lighting, but not RSR, tall R wave, not a very slurred S wave in V6, but a right axis, and a echocardiogram shows a severe pulmonary arterial hypertension and left atrial enlargement. Don't jump into giving a nitrate, sildenafil, rather PD inhibitor or endothelin antagonist in these patients, because if this pulmonary hypertension is secondary to heart failure, left-sided heart failure, pulmonary vasodilator doesn't work. So what worked in this patient? We investigated further and we are lucky enough to have everything. This patient is having CKD because of diabetes. Being obese, the NT-proBNP is high, and she has iron deficiency as well, and she has increased ACR. And what is most important is that after 2 weeks of therapy with drugs, which has been discussed already in previous speeches, including a unique thing, that is CPAP, which was not been tolerable by this patient earlier, but with the new generation of this machine, she lost 2 kg of weight and the biomarker all came down, and she became ambulatory, and she became so confident that she says, I am going to Darjeeling and I am carrying my CPAP machine this time because this is so handy and I am comfortable in taking it. So these are reversible factor, and don't think that they are stepchild. This is a clinical picture of a patient who had a bypass surgery and came with effort intolerance. Here is a guide redness which you cannot appreciate. So this is the uric acid is 11, and this from here a vein has been taken. So this patient is thinking that I am having a problem of swelling and pain, that's why I am not been able to walk, but actually it's a post CABG, heart failure with preserved ejection fraction, gouty arthritis. This patient is again having edema but not much of symptom, and this is because of the bilateral chronic arthritis. He is wearing this kneecap which is producing permanent venous congestion, and she is unable to walk. This is not very uncommon in clinical practice. You need to just give a little time to look into it. চলছে না তো? আচ্ছা, let me see if it works here. Yes. So what is important, সাউন্ডটা কমিয়ে বন্ধ করে দিয়ে আচ্ছা করব একটু okay fine. So I'll just take your attention in these two videos. এটা বোধহয় escape করে দেখছি, হ্যাঁ, তাহলে সুবিধা হবে. Not in the full slide it will come. Just a minute. Here it will come. Compatible নয়?
Maybe this player is not supporting.
হ্যাঁ, okay. হ্যাঁ, ঠিক আছে, ফাইন. এই দুটো ছোট ভিডিও আছে. হ্যাঁ, এটা ভিডিও ফরম্যাটে যদি না আসে তাহলে পরে দেখাবো. তা এনিওয়ে এটা দেখতে পারলে ভালো হতো. সো দিস পেশেন্ট হ্যাজ এ progressively increasing weight gain. There is a edema in the periphery, and that is because of the long-standing use of calcium channel blocker, and he is not worried about it. But when we had a examination on the sacral area, there is edematous, and this patient has a positive hepatojugular reflux, and this patient has a VY collapse with a irregular heartbeat, so you can diagnose atrial fibrillation with heart failure even in the bedside. এটা পরেও দেখানো যেতে পারে, আমি ততক্ষণ নেক্সট স্লাইডে চলে যাচ্ছি. নাও the important thing is how I treat it. If I want to elaborate, I have to say all this thing which has been discussed from the beginning. So the important thing is optimize the fluid balance and treat the comorbidity. And here important thing is, if a patient is having heart failure with atrial fibrillation, he comes into the category of NOAC therapy. Iron supplement, as I mentioned in the previous case, is important. Vaccination in heart failure patient is being recommended. Avoid painkillers, and patient will ask about the Ayurvedic medicine, so just simply tell I don't know, rather than falling into the trap, and we don't really think that we have enough knowledge on these things. Heart failure with preserved ejection fraction, this is very important, and this slide actually says everything. What is important, that ultimately being a adequately functioning pumping heart, still you have a low cardiac output. Why it is so? Because of abnormal ventriculoarterial coupling. When the heart contracts more, there may be more vasodilatation and the patient may feel fatigue. This is one cause. Because of rapid ventricular rate or inappropriate sinus tachycardia or AF with fast ventricular rate, your cardiac filling is less, so cardiac output is reduced. And they all increases or activate the renin-angiotensin aldosterone system. So whether ACE inhibitor, ARB or MRAs are therapy of choice, that the most important thing. They are to be given to control the blood pressure, to control the albuminuria, but unfortunately they don't have any mortality benefit. Similarly, beta blocker, non-dihydropyridine calcium channel blocker is being used, digoxin in the last, but the more important thing is the diuretic therapy, and diuretic therapy is the essence of treatment of symptomatic relief of heart failure with preserved ejection fraction, also of reduced ejection fraction. it doesn't have any mortality benefit, we agree. Spironolactone is a good drug which has been studied, and in NEGM about 5 years back this result came of TopCat study, which has been a very well organized study. Unfortunately, it missed the p-value, but we have seen that there are some patients where if you give spironolactone, the patient's symptom improved and the blood pressure control is also improved. Five slides are remaining. So beta blocker, yes, we must give in patient with atrial fibrillation with fast ventricular rate. We don't believe that diltiazem and verapamil is good than a beta blocker, and patient who has a coronary artery disease or post-MI, they should receive. Thiazide diuretic, we are using less these days. Fear of hyponatremia, which is unpredictable, and you earn once a bad name, the patient is very unhappy. But remember, the trial shows that actually a patient who has a probability of developing heart failure with preserved ejection fraction, this may be a good choice. And last not the least is the SGLT2 inhibitor, and what has been shown that nowhere it has been shown that it is bad as a therapy. Although heart failure with preserved ejection fraction, it doesn't give a mortality benefit contrary to heart failure with ejection fraction less than 40% or ejection fraction which has been improved. But still it has a morbidity or heart failure hospitalization therapy, and that has been delivered by this delivered trial, which has been followed up for more than 3 years, and they have shown the significant composite endpoint of CV death or worsening heart failure. Again, if you pinpointly wanted to ask me whether it decreases cardiac mortality, answer is question mark. But a composite endpoint is definitely has been reduced if the patient is on dapagliflozin on this subset of population. The last 2 slides that probably we'll be using, or we are using more SGLT2 inhibitor. So apart from urinary symptom, tell these patients that in extreme of climate or in period of febrile illness, or if they have a bad peripheral arterial disease, they need to be warned about possible complication. So in conclusion, in 10 minutes you cannot cover this therapy. There is no therapy for heart failure with preserved ejection fraction. You need to pick up the accompanying ailment and treat them. And if you treat them, probably you can have a better long-term outcome. And the most important thing is cardiac rehab, which is probably going to come in a big way in this population. Thank you. এটা তো রান করেনি বোধহয় ভিডিওটা, যদি থাকতো একবার দেখিয়ে দিতাম, মানে এটা তাহলে ওদের।
Thank you, Dr. Sumit Banerjee, for very nicely discussing a difficult subject of heart failure with preserved ejection fraction. And we know that 50% of our patients of heart failure are with preserved ejection fraction, and it is multi-system disease. He has nicely mentioned that all the comorbidities should be taken care of with having some benefit of MRA and SGLT2 inhibitor. So we know that in heart failure with reduced ejection fraction, even after giving guideline directed 4 pillars of therapy, there is residual risk. And sometimes there may be issue of hypotension, CKD, or heart rate. So in that case, vericiguat, a soluble cyclase stimulator, is very useful. And for this subject, I am having pleasure to invite Dr. Sunil Iyar to discuss on this very important topic.
So, respected chair, respected seniors, colleagues, friends, and ladies and gentlemen, and that's very important that there is anything beyond guideline directed medical therapy. And as Dr. Bhansali said that in spite of all the 4 guideline directed medical therapy. So the idea of residual risk came from the DAPA heart failure therapy trial, that in spite of patient getting all the 4 pillars or the 4 guideline directed medical therapy in the intervention arm, still had events. There were 14% of patient that in DAPA heart failure, they had events of heart failure in spite of getting 4 directed medical therapy. So that was the reason that something else has to be done beyond the guideline directed medical therapy came in the mind. So why was that? Because of the worsening heart failure. And the chronic worsening heart failure is the patients who 80% who gets hospitalized for heart failure would ultimately develop a worsening heart failure. And if you develop worsening heart failure, 1 in 2 patient would get readmitted once he gets admitted for worsening heart failure in 1 month, and 1 in 5 patient would die within 2 years. So we all know this slide was shown by Dr. Arindam Pandey, but this is important, that heart failure is a progressive disease, and at all stages you need to care about it. And even if the patient was at a risk of heart failure or pre-heart failure, the treatment should be given so that he does not progress to the other stages of the diseases. And the stage C, or the symptomatic heart failure or the clinical heart failure, the patients on 4 guideline directed medical therapies, the patients on ICDs, patients on CRTDs, still their course is not smooth, and they are punctuated with different events of worsening heart failure. And these are worsening heart failures, and if you don't take care of this worsening heart failure, either the patient would succumb or the patient would go to advanced heart failure, and then he would require a cardiac transplant or LVADs. Now, the definition of worsening heart failure is different from, it has got a separate identity altogether. So what is the definition? The worsening symptoms and signs of heart failure requiring intensification of the therapy, especially the diuretic therapy, and it should be in patient who is known to have a pre-existing heart failure. So that is important, that a patient should know that he is in heart failure, and on top of it he has got again a decompensated heart failure for which the diuretic therapy is required, and this is because of disease progression. The treatment could be in hospital if he is very badly decompensated, or it could be in the emergency department that he comes and gets an IV diuretic and goes back home. Or it could be even the ambulatory increase in IV diuretic, or even increase in the oral diuretic doses. Now this has been recently included in the guideline. Till then, because the guideline inclusion in Victoria trial, or the trial with vericiguat, was not including patient escalation of oral diuretic. Recently in 2023, the ESC statement came that even increase in oral diuretic should be considered as worsening heart failure. Now this patient should not be de novo heart failure. So first heart failure is not worsening heart failure. So de novo heart failure is not worsening heart failure. Neither there should be any concomitant factors like ACS, as Dr. Pandey was mentioning, that ACS or a viral fever or acute pneumonia, there should not be any precipitating causes or precipitating illness. There should not be any requirement of no changes in the heart failure therapy. So these patients are patients who had no event or like ACS or an infection or a viral illness that led to worsening of heart failure. It is the patient was on medical therapy, the patient was compliant with the medical therapy, and still on top of it he had worsening event. So that is the definition which has to be kept in mind, and not that there was any precipitating cause. So we know that the treatment of heart failure is changing from the old age of diuretics and digoxin to the neurohumoral basis, and we have targeted all the axes. The RAS axis being targeted along with the neprilysin. The natriuretic peptide axis has been targeted by ARNI. The sympathetic nervous system is targeted by beta blockers. The SGLT2 is targeted by the SGLT2 inhibitors. Only the nitric oxide soluble guanate cyclase, cyclic AMP axis was left, and this has been targeted by vericiguat, and that is important in worsening heart failure, and that is the 4th or the 5th pillar, or the beyond the guideline directed medical therapy. So what does it do? the vericiguat, it directly stimulates the soluble guanate cyclase irrespective of the nitric oxide. We know that heart failure is a nitric oxide deficient state. So we know that nitric oxide stimulates soluble guanate cyclase, but because of the deficient state, we have a direct medicine which stimulates the soluble guanate cyclase, which causes formation of cyclic GMP and the benefits altogether. Not only that, it causes, irrespective of the nitric oxide, whatever nitric oxide is present also is being sensitized by vericiguat to work on increasing the soluble guanate cyclase and ultimately increasing the cyclic GMP. And what happens if there is increase in cyclic GMP? There will be less myocardial stiffening, there will be less left ventricular hypertrophy, there will be less ventricular remodeling, there will be less fibrosis, there will be less renal fibrosis, there will be increased renal blood flow, and there will be less venoconstriction and neutrophil functions would improve. These all mechanisms, it does not just work on the heart, it works on the kidney as well as in the endothelium, on the vascular structures. Now, if you see the contemporary heart failure trials, this is the Victoria trial with the vericiguat. These were the most sickest patient, and 100% of the patient were in worsening heart failure. None of the trial, if you see that heart failure hospitalization within last 6 months was 84% in the Victoria trial, whereas none of the patients had so much of heart failure hospitalization within last 6 months. And if you see the NYHA class 3 and 4, they were 41%. And the most important point, the primary event in the control arm, means the arm which was not receiving the medicine, was as high as 37%. So they were very sick patient, and they were dying of because of the disease progression itself. So the Victoria trial, the inclusion criteria was symptomatic chronic heart failure. On top of it, the patient was in NYHA class 2 to 4, left ventricular ejection fraction 45 and below, and the patient was compliant on all available guideline directed medical therapies. Still he has a worsening heart failure event with recent heart failure decompensation, which required a hospitalization within last 6 months, or a IV diuretic outside the hospital, or even the escalation of oral diuretic with the elevated natriuretic peptide. And once the patient is stabilized, if he is getting admitted, and what is the definition of stabilization here is the patient should be off IV treatment in last 24 hours, and the patient should have a systolic blood pressure of more than 100, and there was no run-in period, and the patient was to receive vericiguat. Now, if you see the baseline characteristic, again, the 41% patients were in class 3 and 4. 10% of the patient had a GFR below 30, though 90% of patients had a GFR above 30. That was equally divided between 30 and 60, the 50% and above 60% were 50% of the patients. And biventricular pacemakers and ARNI therapy was in 15% of the patient. 84% of the patients were hospitalized for heart failure within 6 months, and that was important in this trial. Now, if you see the background therapy, and as I said that 70% of the patients were receiving beta blockers, ACE inhibitors and MRAs, and the 3 medical therapy, because when this trial was done, SGLT2 was not recommended as a heart failure drug. So the 3 therapies were there in 60% of the patients. However, 14% of the patient did receive sacubitril valsartan, and 14% of the patient had biventricular pacemaker. Now, if you see diabetes, 50% of the patient included in the trial were diabetic and 50% were non-diabetic. And as I said, that GFR less than 30, there were 10% of the patient, and 90% of the patient had a GFR above 30. That was between 30 and 60 were 50% of the patient, and above 60 were another 50% of the patient. Now, this is the data. The primary endpoint was seen that there was an absolute risk reduction of 4.2 events per 100 patients per year, and the number needed to treat was as low as 24. So you must be worrying that why the results are not given in relative risk reduction, why in absolute risk reduction. So if you remember my previous slide, they were very high risk patients. So the events were very faster. So if you see by relative risk reduction, there will be no significance which could be seen on statistics. So the statistics were declared in absolute risk reduction, and in fact there was so much of benefit that the trial was to start for 2 years, was ended at 10 months because of so much of benefit in these patients. Now, there was no differences between the risky patients, like there was no difference in blood pressure if the patient age was below 75 or above 75, if the systolic blood pressure to start with was more than 110 or less than 110, or if the patient was receiving ARNI or no ARNI, there was no significant drop in blood pressure who received vericiguat. Now, there was no changes in GFR in patients who received vericiguat. Similarly, there was no changes in creatinine over time, and neither there was change in potassium in patients receiving vericiguat versus placebo. So tolerability of vericiguate, it was good that the adverse event or the serious adverse event leading to discontinuation of medicine was similar in vericiguate and placebo group, and hypotension or syncope because of vericiguate was again similar in patients who received vericiguate or placebo group, and about 93% of the patient in the Victoria trial could achieve the target dose of 10 milligram within 10 months of their therapy. So vericiguate is suitable for vulnerable patients, and which are these vulnerable patients? Patients at a risk of hypertension, patient at a risk of renal impairment, and patient at a risk of hyperkalemia. That these are vulnerable patients, and vericiguate appears to be an important medication apart from the guideline directed medical therapy. And should you wait for another heart failure or worsening heart failure event, or should you start vericiguate? So the right time to start vericiguate is the first worsening heart failure event. It could be in hospital, because 11% of the patient in the Victoria trial started the medicine in hospital, and about 85% of the patient were started in outdoor clinics. So the first worsening event is the event where you should start vericiguate with the guideline directed medical therapy rather than waiting for another worsening event, because we know that with each worsening event, either the patient is going to succumb to the event, or he is going to go to advanced heart failure. Now, so your patient should have stopped IV diuretic at least 24 hours prior. The volume status and diuretic therapy should be optimized prior to initiation of vericiguate. There is no data or no role of anti-proBNP label that has to be included in this to patient to receive a vericiguate. The systolic blood pressure should be more than 100 millimeter of mercury. The GFR should be more than 15 ml, and the other heart failure therapy should be continued. So this is the clinical algorithm for the treatment of patient with worsening heart failure. So once the patient is stabilized from worsening heart failure, if the patient can receive the background heart failure therapy like the ACE inhibitors or the RASI blockers, beta blockers, MRAs and SGLT2, yes, he should be. So that is clinical scenario 1. And which is these patients? These are patients who are treated in outdoor, that they were on guideline directed medical therapy. For some reasons they are gone in worsening events, so they should be continued on the guideline directed medical therapy, and vericiguate should be added and it should be initiated. Now second is, if the background therapy could not be started. Why it could not be started? Because either that was contraindicated, or there were side effects, or there was intolerance. Contraindication, suppose if the GFR has fallen to below 30, that you cannot start a ARNI, you cannot start, if the GFR has gone below 20, you cannot start a SGLT2. So those are the patients. Will you wait? No. You would still start a vericiguate, even then the patient is not receiving the guideline directed medical therapy. Suppose if the patient is not receiving guideline directed medical therapies and there are no contraindication, then complete the background heart failure or the guideline directed medical therapy and start vericiguate, which can be started concomitantly with the guideline directed medical therapy, or can be started once the guideline directed medical therapy is given to the patient. So these are the 3 tablets which are available in the market: 2.5 milligram, 5 milligram and 10 milligram, which is the maximum recommended doses, should be escalated every 15 days. And you should make sure that every 15 days from 2.5 to 5 milligram to 10 milligram, and the maximum benefit is achieved with 10 milligram. 2 things you need to be kept in mind, that if the systolic blood pressure has gone down below 90, then don't escalate the doses. You can just continue with the doses of what the patient is receiving. Only if the patient's systolic blood pressure is above 90, then you escalate the doses. And secondly, don't use it with if the patient is receiving any PDA5 inhibitor along with for any other reason. So it is contraindicated to be used with another PDE5 inhibitor. So vericiguate approved and recommended for patients with heart failure with reduced ejection fraction and a worsening event by restoring the nitric oxide soluble guanate cyclase cyclic GMP pathway, which is deficient in patients with heart failure, is activated with this medicine. So we have learned about the guideline directed medical therapy. All are inhibitors. This is a stimulator. So that is very important that it stimulates another pathway, and it reduces significantly reduces heart failure hospitalization and cardiovascular death, and the number needed to treat is as low as 24, and it has got a minimal impact on systolic blood pressure. The drop in blood pressure is to extent of 1 to 2 milligram, and it is approved and can be given up to a GFR of 15. So I stop my talk here, and thank you for your patience hearing, and I could finish in time is important so that we can take the question and answers if any. Thank you.
Thank you, Dr. Lila. I think we can initiate some discussing points. Start with Dr. Lila. Is vericiguate is efficacious for prevention of sudden cardiac death. It is definitely a new horizon in the therapy.
Well, we have.
Because one of the mode of death in heart failure is sudden cardiac death.
Yes, so we have only Victoria trial right now with vericiguat, and it was a 10-month trial. So it did not show that there was any improvement in ejection fraction, or there was improvement, or there was reduction in sudden cardiac death. It was mainly the hospitalization for heart failure benefits were there, as far as the primary endpoint, which was the cardiovascular death and hospitalization for heart failure. And it was mainly driven that there were less incidences of hospitalization for heart failure rather than improving sudden cardiac death. Having said that, in patients who are in Victoria trial, who ultimately continued with the medicine 10 milligram, they had improvement in their ejection fraction beyond 18 months, and there were also reduction in few sudden cardiac death. Though the reduction in the increase in ejection fraction was to a tune of 2 to 4%, but 10 milligram has to be given to improve the ejection fraction, and it has to be sustained continuity of the medicine, which is more important rather than just giving in lower doses like 2.5 and 5 milligram. That would not going to suffice your problem.
There means still now this data of vericiguat is initially for first few weeks to few months there is no improvement in risk of sudden cardiac death, but with time it is showing that it can improve in this area also. The major mechanism said from vericiguat is endoplasmic reticulum trace. That means how the calcium and protein synthesis getting handled, that is getting changed with time. That's a new area of research is coming up with vericiguat, that it has got some effect on endoplasmic reticulum trace, and its gene can be less activated in this scenario, because all heart failure is a sick cell state, and there are three areas of concern. One is lipotoxicity, because major metabolic shift is from glucose to fat. That's why there is a lipotoxicity. Second is oxidative trace, and third is endoplasmic reticulum trace. These three are the major killer for sudden cardiac death and arrhythmia. That is the basic cellular initiation of sudden cardiac death. Dr. Banerjee, do you have any comment on incidence of sudden cardiac death in heart failure with reduced ejection fraction and preserved ejection fraction?
We actually have experience on heart failure with reduced ejection fraction for a long time, and that's how they have categorically came up before this GDMT came up, that 40% patient will have a ongoing heart failure, 40% will have sudden cardiac death, and another few will have infection or neoplasm. So this will be the cause of death. For heart failure with preserved ejection fraction is such a new entity, so we don't have actually the right data, but probably
what
the
is the
subset,
trend?
if you say, they should actually, they are more susceptible to get a sudden cardiac death. But the mechanism is complex. Mechanism of sudden cardiac death in heart failure with reduced ejection fraction is most of the time a ventricular event where a ICD can prevent.
That means there is no major difference, but a bit less with preserved ejection fraction. But mechanism of arrhythmia here is more really triggered arrhythmias. Triggered ventricular arrhythmias, and also supraventricular arrhythmias are also more prevalent with heart failure with preserved ejection fraction.
Just one point to make. Yes. One ejection fraction probably is the strongest predictor of sudden cardiac death, and that is why probably none of the trials with beta blocker has shown benefit in preserved ejection fraction heart failure, because the ejection fraction now is more, so chances of arrhythmia as well as arrhythmic sudden cardiac death is already low. So that may be one of the reasons why beta blocker is probably not being successful in this group of patients.
That's why there is a guideline that Dr. Banerjee, I think, mentioned everything. That one thing, that all patients with heart failure with preserved ejection fraction should be separately evaluated for risk of arrhythmia and death. And that will be, is there in history of syncope, pre-syncope, any pulse irregularity, if required extended Holter monitoring, whether there is any risk of sudden death is there or not. This is a very fascinating substate. We cannot conclude from the guideline. That's why those patients should be evaluated for risk of sudden death in next few days or weeks. Up to 30 days, there is a very high risk. This 6 cell state will persist for 3 to 4 weeks. By that time, there may be a risk of sudden death.
May I ask a question? Dr. Sumit Banerjee, questions to you. I'm giving you a case history. A obese patient with BMI 35, aged 75, hypertensive, on antihypertensive medication, including CCB. He is not diabetic. He doesn't have, his kidney function is normal. Now, since he is having SOB, so and he is obese, so I went for to check pro-BNP. As he is obese, as he is aged, his pro-PCNP are normal. His echo window is poor. Okay. So, and as he is non-diabetic and his kidney function is normal, if the patient would have been diabetic, then it would have been, my life is easier. I wouldn't prescribe this DPP-4 inhibitor, okay, SGLT2 inhibitor, okay. Now, as is hypertensive, should I go for this ARNI? Should I go for, as is SOB, but his functions is, pro-BNP is normal, his echo window is poor. So should I go for this SGLT2 inhibitor only on clinical ground? Okay.
Yeah, this patient has hypertension.
This patient hypertensive
and obesity.
Obese, orthopedic OSC history, obese, elderly, but non-diabetic, non-CKD.
Every point in this patient to give SGLT2 inhibitor. Now the thing is, it's a clinical trial. If the patient doesn't have any obstructive uropathy, and I hope there is nothing, you can try with this. The other thing is that if you have a suspicion that the patient still can have a dilemma of taking it because, sir, my blood sugar is normal. So why we can just give furosemide half tablet twice daily and see the effect?
Why shouldn't we give MRI, this finerenone? Okay, now
no, not finerenone. In non-diabetic, we don't have the result. Let it come for a while, but the most important thing is that I have seen that if you give small dose of loop diuretic and just see how he is doing. If he has improved symptomatically, then stop that and long-term SGLT2 will be better.
Trial was not negative trial.
No, TopCat was not a negative
trial. Should we add electron in that pattern?
You can, but it's again not a refractory hypertension, so that is only one thing.
So, very important, the TopCat was a negative trial overall, but there are many questions on TopCat. Finerenone, fine art study, probably was mentioning fine art study, top line results are out. In preserved ejection fraction, probably the molecule is positive, though we don't have the detailed analysis. I would like to mention one point regarding out of SGLT2 inhibitor and this mineralocorticoid receptor antagonist in your particular patient. One option, I do agree with Dr. Banerjee, you can give a trial of diuretic, mostly furosemide, because if the patient is having volume congestion feature, which you are not being able to pick up due to clinical enigma, then it might improve. But this particular patient will definitely benefit from injectable semaglutide. We have a data, clear-cut data. Yes. Obesity associated heart failure, it is a positive trial and your patient actually fits about it. He may or may not be diabetic. So in this patient, you can actually try injectable semaglutide, which is not available in our country. So you can, as an alternative, you can give it a trial of oral semaglutide. Very ideal.
Just to add in this area, I have told at the beginning, CKM syndrome that has been introduced last year. That CKM syndrome, what we are discussing, I think the topic I have seen, whole day is discussion on CKM syndrome. Because in October 2023, AHA has introduced this terminology, cardiovascular kidney metabolic syndrome. Stage 0 means nothing. That means if we do something there, that is a primordial prevention. Stage 1 means obese, and that obesity is a dysfunctional obesity. That means that lipid is toxic to the body. Adiposopathy.
I am putting this question in another way.
That means from that area, these new molecules are getting introduced.
I am putting this question in another way. If a patient of diagnosed heart failure with preserved ejection fraction comes, what should be the first line drug, what should be second line drug, what should be third line drug?
Based on symptoms. Because most of the pillars of heart failure will not work in heart failure with preserved ejection fraction.
Coming to your query, the first line drug has to be SGLT2 inhibitor because they are now as1 medicines in heart failure with preserved ejection fraction. If the patient is hypervolemic or if he is congested, that for some time you would give a diuretic to decongest him. Now, the most important thing is coming to your query. I'm sure you must be asking that should I go with conventional hypertensive medications or should I go with ARNI? Now that is now here comes the Paragon trial, which was again just a miss by a whisker 0.06 thing. So there was a problem with the Paragon trial. The Paragon trial, I don't know for what reason, they had taken active component in the control arm. Why did they take an active component? Because there is no class 1 indication medicine that time. Telmisartan was a class 2B. Why they did not do a trial with the placebo in control arm and with the ARNI? So they did, what they did was ARNI versus the valsartan. So why did they take an active arm?
Then I think everyone is agreeable that SGLT2 can be given in any stage of heart failure.
Yes, it is.
So I think first line of drug should be SGLT2
yes,
inhibitor.
first is SGLT2 diuretic if the patient is congested, and if the patient
And
doesn't
diuretic
mind,
preferably this MRSA.
no. First you have to give a loop diuretic
Loop.
to decongest the patient.
Even SGLT2 in CKM stage
Yeah,
1,
that
that means
also.
obesity with glucose intolerance.
And
You can give SGLT2 inhibitors.
third, you can discuss with the patient that ARNI can be more beneficial. That is one-to-one discussion with the patient is important to give ARNI rather than telmisartan. So that is important because both are
As
class
heart
2B.
failure with preserved ejection fraction is multi-system disease.
Yes.
So you have
Every
to take care
individual
of-
is different.
take care of all the comorbidities first.
Absolutely.
One comment about that 50% of our chronic heart failure patient and 70-80% of our acute heart failure patients are iron deficit. So iron therapy should be given.
Absolutely.
If ferritin is less than 100 or ferritin 100 to 300 with T-set less than 20%.
Of late, ferritin is out of the
Measuring,
T-set,
yes.
only
T-set
T-set
less than
is, you
20.
do
T-set,
not see the
T-set.
ferritin anymore. If T-set is below 20,
20,
then you should give iron.
IV iron.
You don't need to
Improve
see ferritin.
prognosis.
Preferably IV iron, not oral.
One point Dr. Prakash asked me about the probability of sudden cardiac death in heart
Yes.
failure, preserved ejection fraction. We have not discussed 1% of population that is familial hypertrophic cardiomyopathy,
Cardiomyopathy.
where MRI shows a significant scar burden, where a primary prevention of sudden cardiac death young population may be very challenging, and maybe actually we should give this therapy. So probably I have
Arindam,
missed
you
this
have Arindam has mentioned one, the psychological assessment and treatment. Is there any relation with sudden death? Yes.
Obviously.
Yes, that part to be taken care of. It has been shown that it can be doubled. If there is a too much depressive episode or anger episode, chance of sudden death is also get doubled. Rehospitalizations also got increased.
It has so
any
direct
form of
relation. It has so direct relation. We get a cardiomyopathy known as Takatsubot cardiomyopathy. So apical ballooning, ejection fraction drops like anything, and if we treat the underlying psychological issue, it is a completely reversible cause of cardiomyopathy. So psychological assessment of all chronic heart failure patient as well as de novo heart failure patient is extremely important and has to be given proper, respect.
any nutritional yes.
May I ask one question to Dr. Leela? See, if you see the paradigm heart failure, Paragon heart failure, the main difference is here the ejection fraction, and it has been shown that lower the ejection fraction, better is the response. So far as the CV death and hospitalization for heart failure. Even if you see the trials driven by the SGLT2 inhibitor, in case of the preserved ejection fraction, the benefits mainly comes from the hospitalization for heart failure rather than the CV death. On the other hand, where the ejection fraction is less than 40%, there are benefits of both the CV death as well as heart failure hospitalization individually. But in your Victoria trial, you have shown that the benefits comes mainly due to hospitalization for heart failure rather than the CV death. So how to explain this apparent paradox? Because I think that probably in this trial, the patient was quite sicker, so their ejection fraction
So
must
that
be
is,
lower.
that is the answer as you have given, that these patients are very sick. So how much would be the death benefit is a big question mark to those patients, you know. And if you see the subgroup analysis, I did not talk because it is not a forum of cardiologists. If you see the subgroup analysis by anti-pro-BNP in the Victoria trial, patient who had anti-pro-BNP below 5,000 even had a cardiovascular death benefit. Only once the anti-pro-BNP were 5,000 and above in inclusion, that there was no cardiovascular death benefit, and in fact the benefit of all the guideline directed medical therapy also plateaus and they die down. And in fact by above, if it is above 8,000, none of the medicines are beneficial. So cardiovascular death benefit per se in the Victoria trial was not significant, but if you subclassify them by the anti-pro-BNP, who had anti-pro-BNP below 5,000, they had even the cardiovascular death benefit along with hospitalization and heart failure reduction. But if the anti-pro-BNP was on the higher side, it was mainly driven by hospitalization for heart failure rather than cardiovascular death.
So
Major idea of Hariciguat therapy was to make more sarcomere to get more overlap during systole. Ideal length is 1.08 to 2.2, that area to be overlapped. That means dark band area. That was the idea, molecular idea of Hariciguat, to make the cell more overlapped so they can contract. That's a more of mechanical benefit. In a dying cell or dead cell, and there are a few myocardial cells are alive and they are not contracting properly, Hariciguat is the cellular target to those cells. Make them more overlap so that they can contract. That's a mechanical benefit mainly. That's why sudden death benefit is not there initially, but on long term, when there is a improvement, it is evident that there may be some benefit from sudden death also. Main molecular idea was to make the cells more overlap during systole, this sarcomere overlap.
Sir, I'm really sorry, sir. We'll have to conclude. I mean, sorry to interrupt.
I think that's a good discussion.
Yeah. So this conversation is never going to end. So thanks a lot for a very interactive session.